All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So, today is the discussion in the long COVID series. The discussion is that researchers from Affairs Hospital, St. Louis, and the Department of Veterans Affairs, and using the database from Veterans Affairs, they have found out that the risk of excess diabetes in COVID patients, even mild COVID patient, is increased, and it is increased on a larger level by 40%. And there is an excess of about 9 cases per thousand per year. So diabetes is increased, or diagnosis is increased. So let's look at this study. It is actually a very important study, because what it means is that the doctors who are treating the patients for diabetes, the endocrinologists, they have to keep in mind that patients who had COVID will have an increased risk of diabetes. This was actually seen with SARS-CoV-1 as well. You may remember that I had discussed a study about SARS-CoV-1. 10 years after, a larger number of people with the same age comparison to non-SARS-CoV-1 infected people had increased number of diabetes cases. We are seeing that here as well. So let's look at this discussion. So first of all, this is drbeen.com. There is a link in the description that gives you drbeen.com almost for free. And I don't tell the price because I actually intend to remove that price. It is too low, but for some days, let's work with that. This is the study. So the researchers are, if you see here, this is Yan Shi, Department of Epidemiology and Biostatistics, College for Public Health and Social Justice, St. Louis University, St. Louis. Then we have Ziad Ali, correspondence to Dr. Ziad Ali Clinical Epidemiology Center and Development Service, Veterans Affairs, St. Louis Healthcare System, St. Louis. So these are the researchers. The publication is March 21, 2022. Then there are some PDF that I would show you. There is a summary article written as well that is also linked in the description, Rising Diabetes Diagnosis in Long COVID. Then there is this CDC article. What is the importance of this article? I wanted to show us what is the regular incidence for the diabetes. So if you see here, incidence estimate 2018 to 19, rate per thousand. And if you see here, total is 5.9 per thousand cases per year. And then the numbers are different for various age groups. You would be kind of, I think, surprised that greater than 60 years of age, 5.8 cases of diabetes, I believe it is per 1,000 persons per year, versus 45 to 64 years have 10.1 cases per 1,000 persons per year. The reason is that diabetes normally begins in this age slot. That is why the rate is higher. So, anyways, this is that. And then there are some other discussions as well. For example, here this is a discussion about incident diabetes mellitus may explain association between sleep duration and incidence coronary heart disease. Then what is risk ratio? This is US's count. So this is important to keep in mind that US has a total of 79.8 million cases so far. Let's call them 80 million cases. And then there are some more references as well. So with this, let's start. So I have no disclosures. This is the latest painting I had, rainy day at Silver Ridge, California. It was actually raining and I was sitting in my car and I was parked here in front of the scene, and sitting inside the car, I was painting it. So we are in the Omicron time. This is a medical disclaimer that this discussion is not a medical advice. It's more of education and information. So here is a study summary. The summary says or demonstrates that the rising diagnosis of diabetes is occurring in long COVID patients. That is one. Second, rising use of incident antihyperglycemic use in long COVID as well. And I should the one here, rising diagnosis of diabetes, can also be said as rising cases of incident diabetes. So incident diabetes would mean new onset diabetes, new diabetes case. Similarly, incident anti-hyperglycemic means new beginning of anti-hyperglycemic drugs or anti-diabetes drugs. This is the basic summary. So how increased? 13.46 cases excess is the burden of incident diabetes per thousand people per year or at 12 months. So let's say we have 1,000 people and you observe them for a year, and out of those 1,000 people, 10 people get diabetes. If these 1,000 people had COVID, then instead of 10, 20 will get diabetes. That is what they're talking about. So here they're saying for 1,000 people who had COVID, there is an additional 13.46 number of excess cases per thousand. Now the question is, what is the actual number of cases without COVID? So let's look at that. So burden in non-COVID persons per year per 1,000 people is 34.93. So 1,000 people over a year time, out of them, 34.93 will develop diabetes according to this study. You saw CDC says about 10, or they have various age groups. Their total for 2018 and 19 says 5. This study actually used their own cohort. They used 3 cohorts. One was COVID positive patients. The other cohort was in the contemporary time, non-COVID patients. But there is a risk of having contemporary patients or current time non-COVID patient. They may be asymptomatically COVID. So they also went before the pandemic and had, of course, non-COVID. They had patients from before the pandemic as well, or people from before the pandemic. These were the 3 groups. And when they compared COVID positive to the control or healthy groups, other 2, the result was 13.46 excess. And in those other 2 groups, the count was 34.93 per thousand per year. With the COVID, the count became 48.38 per thousand per year, and that difference is 13.46. This also is a 40% increase in risk. So increased risk, hazard ratio is 1.40. So 0.40 is what is interesting, and that is 40%. So that's a very interesting number. Patients, and if you ask me what are the patients, they had patients who got COVID and they observed them for 30 days after COVID, or the patients who survived COVID after 30 days, meaning they had not died. These are the patients. Then they observed them for 12 months, and here is the outcome: 40% increased risk. So here is a quick chart which I took from the study. In here, if you see diabetes, anti-hyperglycemic use, and composite outcome, this is the overall number. If you just look at this chart and understand it, then the rest of the study is just details. What this says here is, if we start from the top row, it says diabetes in COVID-19 patients was 48.38, that I just showed. In the contemporary control, that is control group that they formed from the current time people, 34.93 per thousand per year. And you saw the difference, 16 point something. Anti-hyperglycemic drug use. That means people started using anti-hyperglycemic. Why? Because they were becoming diabetic, or they were diabetic. So 27.04 per thousand per year versus 14.69. This is almost double. So 14.69 versus 27.04. So if I can kind of manipulate the number a little bit, 14 versus 28. Right. So it's about, I mean, these numbers are about 80 to 3% change. That is the increased usage, risk of increased usage of antihyperglycemic drugs. That's not good. Composite outcome, both of them together. COVID 19 patients, 58.10 per thousand people for 1 year or 12 months versus 40.07 per thousand people for 1 year. So that is the change. So once again, it clearly shows that the patients of COVID develop more patients of COVID develop diabetes compared to control. Now, I also went out looking for vaccines as well, because if COVID is going to do it, then it is possible that vaccines would do that too. And I found a few studies. I did not go too deep in them because I wanted to do this discussion. But one study I have linked in the description, that study showed that post vaccination hyperglycemia occurs. Now, how long does it stay? Does it become chronic? Does it end up causing damage to pancreas? Is not yet known. That study was not able to find that, but they were able to find increased glucose levels, I think, for a month after vaccination. Now, that was the risk of diabetes in excess. How much is excess? About 14 people, extra people, or 40%. Now is the anti-hyperglycemic drugs use. We're still at the summary. Rising use of the anti-hyperglycemic drugs. So how much rising? Overall, bigger picture. 12.35 excess burden of incident anti-hyperglycemic drugs, meaning incident means new onset anti-hyperglycemic drugs per 1000 people for 1 year. So what was the original cases? So there are 12.35 extra. What was the original count? The original count was non-COVID people in 1 year, out of 1000, 14.69 start taking anti-hyperglycemic. If they had COVID and they were 1000 people and you observe them for a year, 27.04 would start taking anti-hyperglycemic drugs. So the risk is increased, and that is 85% increase. So hazard ratio is 1.85. Absolute number 12.35 excess diabetes cases, or here the use of anti-hyperglycemic per thousand per year. 85% increased risk. So once again, the same table. Now, composite endpoint, I just described that before as well. Composite means combining both of them. If you combine them both, the hazard ratio of diabetes or usage of the diabetes drugs is 46% increased, and overall burden, excess cases, is 18.03 per thousand per year. So once again, 18.03 per thousand per year looks small, but compare it to what is expected. What is expected is about 30, and instead of that, here we have plus 18. So details. So this is it. If you were just interested in the summary, we're done. And shout out to Texas Meg. This was her uh, reference for this study. So Texas, thank you very much. Now I'm going to go in the details of this study. So details are, they made three cohorts or three groups of people. One group had 181,280 COVID-19 survivors, first 30 days of COVID, and they started them from March 1, 2020 to September 30, 2021. They finished their follow-up on end of December 2021. Then they made one more group that they called contemporary group. That group was non-COVID persons from the same year as the COVID, so that is 2020. Then they had a historical group to make sure that they do not have asymptomatic patients added in the second group. They created a third group, in that is the people from 2017. The COVID group itself was further divided into three: mild cases or non-hospitalized, then within the hospitalized, that is the people in the hospital, and then ICU bound patients. So they divided them in these three. And I'll show you a table. They have a really exhaustive data analysis for severity of the disease and relationship to diabetes or risk for diabetes, then age and risk, race and risk. But the ethnicity and race has a problem. 75% of the group was whites. So the non white data is kind of not with a good power. Number one. Number two, this data cannot be generalized to everyone because it is primarily for whites. So, continuing, diabetes. What was the definition of diabetes? So, diabetes was defined by International Classification of Disease Code 10, where in this case, hemoglobin A1C 6.4% or more, or 46 millimole millimole per mole. And then anti-hyperglycemic use. It is so funny. I'm not used to uh, these measures. Anti-hyperglycemic use was defined based on the prescription record of diabetes medication for more than 30 days. So that is how they defined these two. Now here is the association between COVID-19 and diabetes was consistent across strata of several potential confounders: age, sex, race, BMI, diabetes risk score, steroid use, and area deprivation score. But once again, there is a weakness of the study that 75% folks are whites. Then, notably, even those with mild non hospitalized COVID 19 patients had an excess 1 year burden of 8.28 per thousand people. This is an important number. So, this is outpatient patients out of 1,008. So, now let's think about it for a second. In the US, what did we have? About a 80 million cases. So if we divide that by 1,000, that is 80,000, multiplied with 8. So about 600,000. There are in 1 year 600,000 extra potential cases of diabetes caused by long COVID or because of long COVID. So, for example, the excess burden of diabetes among non hospitalized individuals was 8.28. So, I just mentioned it. And the authors say that, hey, in the world right now, for example, we have 450 million cases. And if you divide that by 1,000 and multiply it with 8.28, that is the number of possible new diabetes because of association with COVID. So here, global excess burden of diabetes is 3.726 million, about 4 million extra cases. And within the US, 6.62,000 or 662,400, more than 500,000 cases. And this is for 1 year. What will happen the next year is not known yet. So it is possible that the same cohort would continue to develop diabetes. Some developed this year, some would be added next year, and so on. In addition to our analysis of who is at risk of diabetes among people with COVID-19, suggests that the relationship between COVID-19 and diabetes exhibiting a graded association according to baseline risk of diabetes. So this is another important thing. So there is a risk assessment for diabetes. Let me quickly show you this. So here, for example, this is a table that does scoring for type 2 diabetes risk. There is another table over here that does scoring for pre-diabetes risk. So if somebody is at a higher risk of diabetes, then they actually developed diabetes more in excess than compared to those who are not at risk. And I think that makes sense that if the COVID is causing a problem with the pancreas, then somebody who already has a pancreas that is functioning lesser, when they further develop an insult to pancreas, then they would develop diabetes fast. Then children. So for children, they were not very clear. They said a study of two large databases, more than 2.5 million children aged lesser than 18, suggested that those with COVID 19 exhibited a higher risk of new diabetes than compared to those without the COVID. Additionally, the risk of new diabetes was higher in COVID 19 than those with pre pandemic acute respiratory infections. That is, if there are children who had other acute respiratory infections before the pandemic, that is not from SARS-CoV-2 but something else, they didn't have a higher risk of diabetes, but SARS-CoV-2 infection had a higher risk. Now, then they think about what is the possible mechanism. And I know that we would all like to just say it is spike protein and move on. But really, it's not spike protein in general that should do it. And they actually cite a study. What that study is, and now I'm going to draw a little bit as well, that would fix my drawing need. So give me 1 second. So what they did was they cited a study. So let's say there are some pancreatic cells in a petri dish. It's in a lab. So the cells are sitting here, right? So they all should have these arms. So what they did was they infected them with COVID or SARS-CoV-2. And what they found was that a lot of the function was not disturbed because of the SARS-CoV-2 infection. So then, if that is the case, if the virus itself didn't do it, then what caused it? And I think this is where I have been saying this for a long time. It is the immune system. An immune system, multiple possibilities. One is, as you saw, the Neal's theory or the network hypothesis, which says that there are autoantibodies against ACE2 that are formed. So this is our, let's say, antibody. This is another antibody that is produced as a result of COVID. And this antibody is against spike protein. And then there is another antibody that is against this antibody, which is now going to look like spike protein, and that would bind with ACE2 and cause issues. So that is one possibility. The second, so I'll write one here. The second possibility is the inflammatory cells. So when you have these cells, the pancreatic cells in the petri dish, what you're missing is the whole body's environment. And so in the body's environment, there are immune system cells, there are chemokines and cytokines and inflammatory molecules running around, and they can do a number on these cells. So from a mechanism point of view, they're not sure, but they thought one possibility may be the infection, but they say that infection does not show much harm to excuse me, pancreatic cells. Then the other possibility is the autoimmunity. Now, could there be even more possibilities? And they think about that. So let's see. So they talk about pancreatic cell type 2. They have ACE2 on them, they have TMPRSS2 on them, they have neuropilin on them, meaning pancreatic cells have all the mechanisms, all the molecules that are necessary for COVID to bind with them. And then they say that we actually see that in one study they see that pancreatic cell reduce insulin production, in the other study they see that there is no effect. Then they talk about what may be other possibilities, and that is autonomic dysfunction. So this is actually very important. As I'm working on the long COVID and I'm reading up the autonomic dysfunctions in long COVID, many of the long COVID issues could be autonomic dysfunctions. So this is one of them, the pancreatic abnormality. Then autoimmunity that I just described could be autoimmune disease because of the cells, the cytotoxic cells, the macrophages, other cells, or it could be antibodies, anti-idiotypical antibodies that are attacking us. And if you are kind of curious about what these are, I had done a discussion to talk about autoimmunity after vaccine and COVID, because vaccine can do this as well. So autoimmunity, and if COVID can create autoimmunity, I believe vaccine can create autoimmunity as well. So this part of the statement that I'm speaking now, it's not the study. So this is me speaking, so I may be wrong, but vaccines can create autoimmunity as well. We are seeing that, and so that means vaccine could cause this damage as well. I'll speak separately about the vaccines. Then third part, persistent low grade inflammation leading to insulin resistance. This is very interesting, and we have been looking at this, that long COVID patients have continuous inflammation going on. What is the cause of that inflammation? There can be many. Dr. Paul Merrick and I was discussing a few days ago, and he was saying we need to look at all the various possibilities of pathologies or phenotypes. But the end result is that there is a possibility of continuous inflammation. If there is continuous inflammation, then that would mean there is a continuous activation of immune system cells, there is a continuous production of cytokines and chemokines, there may even be continuous clotting and things like that. Then broader contextual changes. For example, a person's social environment changes during the pandemic. Maybe their socioeconomic status changed because of pandemic. That in turn caused stress, which in turn caused insulin resistance. You know that stress causes diabetes, sometimes temporary, but sometimes becomes permanent. And we are actually still shell shocked. We would slowly come out of this, but at this time we are shell shocked. We are actually going through a traumatic time. We just do not know it with enough intensity yet, but our body knows it, because our hormones are responding, our system is responding to the stress. And I believe this is also a situation with vaccines as well. But I want to keep saying, when I call out vaccine, that is not what the authors were saying. This is me adding context here. So, socioeconomic factors can be changed, environmental factors can be changed, even a person's dietary habits, even their physical habits, their exercises, their exposure to outside, what they are eating, all of that is changed. It's 2 years we are locked into our houses or rooms or places. So that is another factor that they thought is important. Then what was their conclusion? So they had a long paragraph for conclusion. I took this one part. Taken together, current evidence suggests that diabetes is a facet of multifaceted long COVID syndrome, and that post acute care strategies of people with COVID 19 should include identification and management of diabetes. Which means when a endocrinologist receives a patient who had COVID, they should start observing them for diabetes. And when you receive a patient who has diabetes, then you should start thinking about long COVID, even if they say, I don't have long COVID. There are many patients who have had COVID, or once again, my addition, vaccine, and then they have developed some symptoms that they are not connecting the dots that this was COVID that triggered these. So if you receive a patient of diabetes, then suspect some exposure to COVID. If you receive a patient of uh, for endocrinology COVID patient in your endocrinology practice, then suspect that they might become diabetic. In addition to this, now this is my part. This is why every day when I read these studies, it becomes more and more clear to me that prophylaxis and then early aggressive treatment is a very important factor to keep the intensity of this disease at bay. Okay, so this is the second part of the talk, the detail. Now I'm going to go into a third part. You are totally welcome to quit that part, and that is I'm going to look at some tables with you. So let's do that. Just a couple of tables which I think are very, very interesting to look at. Here is the burdens. So diabetes hazard ratio 1.40, 40% increase. This is COVID-19 cohort. This is contemporary cohort, and this is excess burden from calculation. So we looked at this number. This is the anti-hyperglycemic use or drugs for diabetes. And look at this number, 1.85, 80% increased risk. And then the other numbers we saw, and this is the composite one. Now, a more interesting table here is figure 3. This figure. In this figure, just a very quick way to look at it, these little the plots over here, these are the ones that are showing the 95% confidence interval plus the numbers. So for example, let's look at it together. Here, let's see BMI. BMI 25 to 30, so overweight, right? If you look at this number over here, this number is telling you the increased risk. So the number goes anywhere, I believe, from 1 point. So if this is 2, this somewhere over here will be 1.5. So 1.2 to 1.4. So 20 to 40% increase. But look at the obese person's risk. So BMI greater than 30 or equal to 30, actually greater. So look at the number, anywhere from 1.8, that is 80% increased, to 2 point, let's say 2. So almost double the risk in someone who is obese. This is the composite outcome, right? So you can look at the same outcome for drugs as well and for diabetes too. So if I go to diabetes, let's see diabetes risk for an obese person who got COVID. So this is the line here. So if I go down, this is more than double the risk. And then it continues on from more than double to almost 2.5 times or more is the risk or the burden of diabetes. Similarly, if you see here, cardiovascular diseases, kind of these are in the that 40% increased risk area. Black versus white, I would not trust this number because they had 75% who were white, so the numbers are not really, I think, that great. Age greater than 65 versus lesser than 65, and that is a number here. I think this is also going above 1.5, so it is somewhere over here. So it's 1.78, so 70% or more increase. So this table will be an interesting table to for you to look at, where they talk about age, race, cardiovascular diseases, hypertension, hyperlipidemia, prediabetes, overweight, and obese, and their risk with diabetes. So this is the discussion. Um, what I'll do is this, that little window of time where I was absent, I would edit that out. In the meantime, I'm gonna come back for a chit chat, but today I'm gonna come back on two channels for chit chat. I'll come back on regular channel. I'll share the link for the other channel. Then from tomorrow we'll be on the other channel. So do me a favor in the meantime, if you would like to support this work, if you like this work, there is a link in this description that is to Dr. Bean's uh, account. And the price is, I always say I don't want to call my 1,000 videos as, I don't want to call it cheap, but they are inexpensive. They're almost like a gift. They're almost free. So take advantage of that. In addition to this, there are other links as well if you would like to support this work by buying me a coffee or using PayPal or becoming a patron. Thank you very much. Please also like, subscribe, and share. And I would come back on the same channel for chit chat, and I would share the other channel's link to go there. And from tomorrow, the chit chats will be on the other one. Thank you very much. Bye bye.